So today I have the pleasure of having two gentlemen who are here to talk to us about a revolutionary technique for pain relief. If we haven't met, I'm Dr. Orlando Landrum, the founder of Cutting Edge Pain Relief Centers. And what we endeavor to do is to really be able to bring new technology and new treatments so that patients understand that they have options for pain relief and are not focused on just having to be stuck with using opioids, surgery, or just steroid injections. Today, I'd really like to be able to introduce both Steve and Lou, who are going to talk to us about Genesys and percutaneous SI joint injections. Gentlemen, thank you so much for joining us.
Thank you.
Thank you, Dr. Landrum.
So I know when I use that terminology, SI joint fusion, a lot of people are like, what the heck is that? What are we talking about? How painful is it? Who is this for? So you got all these different kind of like questions that are just percolating right off the bat. So let me kind of start you guys off with some easy like ones so you can kind of just get on base right off the bat. Can you tell us a little bit about what SI joint pain is?
SI joint pain is a pain that's over almost the buttocks area, and it for most patients is pretty excruciating pain. So there's injections that the Dr. Landrum would start with, and then the next point would be after they would exhaust all of those conservative treatments that they would need to have some type of a more permanent procedure.
Thank you, sir. So as we're kind of describing that, basically, if we're looking at a spine model, one of the things that we'd say is so that SI joint kind of sits within that area in here, or conversely over in here. And you can have pain that goes to a lot of different places, as Steve and Lou were saying. Sometimes you'll feel it in the glute. Sometimes you'll feel it in the lumbar region. Sometimes you actually feel radicular symptomatologies, meaning it's going down the leg, mimicking sciatic type pain. And as you stated, there's a number of different traditional treatment options, like injections into the site, or potentially the aspects of radiofrequency ablation or other things. But really, this is a technology that looks at being able to find something that can be sustainable pain relief, is it not?
Yes, most definitely. It is a fusion procedure where we put in a little chunk of cortical bone graft and also includes some demineralized bone matrix to help the fusion process, to fuse the joint and not allow those pain generators to continue to cause the pain.
Wait a minute, Steve. Wait a minute. You're too fancy. You're too fancy for us. You got demineralized bone and all these bone matrices and stuff, and we just barely got a spine model and a working computer going on over here. So for our audience, when they say fusion, most people think about big rods and screws going into the lumbar region. Can you kind of talk a little bit about the history of how this evolved and said, we don't necessarily need to do that in the SI joint area?
Well, traditionally, there's we could talk about it. There's a lateral procedure where they come in with titanium screws or titanium triangular rods to put through the joint and to fixate it mechanically, in other words, with a screw type of fixation. This type of posterior SI procedure actually goes straight down into the joint with a little chunk of bone, and it's actually going to fuse that joint in a much less invasive way.
Okay, so to that end, can you talk a little bit about this SI joint? Why is it so painful? What causes the pain that's associated with it?
There's multiple different things that could be that could cause this pain. A patient falls. It could be a car accident. It could be actually postpartum from pregnancy. So there's some ligaments there that actually keep that joint intact. And as those ligaments become lax, or in other words, that they become a little bit loose, that joint has a little bit more motion. The joint traditionally doesn't have much motion at all, but any bit of motion that does occur in that joint can cause severe pain to the patient.
So when you talk about kind of that mobility that's in place, you made mention of something that was called a lateral fusion. And I know you didn't want to necessarily confuse people.
Correct.
Because what we're talking about doing is a posterior fusion, and there are differences between them. Let's talk a little bit about posterior. And Lou, can you give us some insight about posterior and what that means?
With the posterior approach, in my opinion, it's a lot more safe approach. You're basically dilating inside the joint with a needle approach. Small cannula goes into the joint, and then a piece of basically bone is being put inside the joint to stabilize it.
I know you guys are smarter than me because you guys are using those big words like cannula and stuff, and I'm like, oh man. So I'm sure you guys are you do this day after day, right? And really, this is kind of one of the things that you help a whole host of people with being able to kind of improve their problems and issues, right? I think you sent over a few pictures for us possibly to kind of look at, so some of our audience can be able to kind of get an idea about exactly what we're talking about. And we're trying to work with some of our challenges and technical difficulties, but we're going to see if we can be able to overcome that and be able to add to what we got going. So let's see if maybe we can kind of jump into some of those pieces that might help a little bit. So as you mentioned, right, you talked about there being different causes like inflammation and trauma and arthritis and infection. But some of the things that you also talked on were pregnancy and potentially previous back surgery. And I think for a lot of patients, they say, well, I've gone through a regular fusion. How could this potentially be a benefit to me? And I think, sometimes we don't recognize the SI joint as being a potential active problem. Do you see that with any degree of frequency, or does that seem a little bit unusual or atypical?
Oh, I think you hit the nail on the head. I think it's very typical that patients come in with that type of a complaint, especially after a long fusion procedure in the lumbar region. Traditionally, the next joint to go would be actually the SI joint. So in other words, all the pressure is on that SI joint, and that could cause some severe pain after a fusion procedure has been done in the lower back.
That's correct, Steve. And there's also data on the SI pain or SI pain generator after L5-S1 fusion. And it says that 43% of patients after L5-S1 fusion could develop SI joint pain.
That is correct, Lubos. Those are studies that have shown that is definitely correct.
So guys, how does this differ from a traditional lumbar fusion? Can you explain that? I know you talked about the cannula. I know you talked about it, but give us some of the contrast, the differences between. And I know you guys are experts in both because you really have, strong, not a few months, but you have years of grounding with and still, have that expertise in that space. Can you explain to us like what goes on in a lumbar fusion and how does that specifically differ from a posterior SI fusion? And for me, break it down for me.
Okay.
Like I'm a fourth grader.
All right. Well, traditionally, a lumbar fusion involves putting some screws and rods. So in other words, we call them pedicle screws into the pedicle, and it actually will fuse that joint. So with an inner body cage, most times it's a cage that's put in the disc space after the disc space is cleaned out. The fusion usually is needed because the disc has collapsed and you're getting nerve impingement, down the leg and down the buttocks areas. So when you do a fusion, they traditionally open up or decompress that nerve and then fuse that, so there is no motion. And that should not be a pain generator in the future. What is your thoughts on that, Lulas?
Definitely. My thought on it is sometimes it's not really easy to identify what's the pain generator, if it's coming from the 5-1 or SI joint, because the SI joint pain could easily be mistaken for a pain like a disc, fragment on disc pressing on exiting nerve root in the 5-1 region. So I've spoken to several surgeons who they've been doing a lot of 5-1 fusions, and now their first look at SI joint as pain generator instead of jumping on interbody fusion at the lumbar region 5-1, and kind of in many instances they try to treat SI joint first with the fusion and maybe then later come back to 5-1 for lumbar for much bigger procedure.
Okay, gents, thanks for explaining that for us. Definitely really appreciate that. We actually had some people kind of jumping in with some questions, but we're going to get to their questions in just a little bit. But one of the things that we really want to kind of enunciate is, so we have this picture off to the right-hand side that uses these fancy words like allograft. And what does that really mean in kind of like that fourth grader language? And hopefully I'm not insulting some fourth graders, because they might be like, I know what allograft is. What are you talking about? But if you could explain to us, what does it do and why is it shaped in that funny, weird kind of way?
Yeah, the allograft is actually, it's human bone that has been treated and sterilized, and it's very common. It's been used for many, many years in the spine industry, and it is a wedge shape, as you can see, kind of with a bullet-shaped nose, and that is to go into that joint and to help stabilize that so there's no motion in the SI joint to help relieve the pain.
So I'm assuming that wedge helps it get into the space, and it helps keep it in the space, I assume. Can you talk about that a little bit?
Sure. The way that the graft has been manufactured, the nose is kind of bulleted so it would find the joint as you are preparing the joint to receive this allograft. And then there's some ridges on there too, and those are anti-migration ridges. And that's, once they are tapped in place, that is locked in there solid into the joint.
Yeah, so that's kind of unique, is it not, for you guys with these little ridges that are in place? I've seen some other things out there, but I think this is kind of like a really interesting design feature that you guys have.
True. It, as from being a Genesys, part of Genesys team, we do, pedicle screws and the regular traditional fusion procedures. We have learned from that these ridges will help maintain or help stabilize the implant so it will not come out. We use this type of technology also when we do interbody cages. In other words, when we place them into the disc space after that's cleaned out. So we use those ridges also for that type of procedure.
Okay. So in a few minutes, we're going to come back and we're going to ask, the two of you, who are some better candidates, and then what can they expect for rehab after this? Like how long are they laid up? Is it for like 6, 7, 8 months? We're going to take a quick little break and we'll be back in just a few seconds. Okay, so we're back and we're talking about posterior SI fusions and how it can be able to help SI joint pain. Again, I'm joined with two gentlemen who know all about sacroiliac joints and how to be able to make them feel better. Thank you so much for joining us, guys.
Thank you.
You're sure welcome. Thank you.
So one of the things that we were interested in is kind of what is the patient, how do they evaluate if they might be a good candidate for this? Can you, we know that there are certain conditions like, you have ligamentous laxity from previous pregnancies, if you have trauma that's there, or degenerative disc, but how do patients kind of assess it on their own? What might they think to say, you know what, maybe I might want to look into talking to these two guys that I have up here on camera, or maybe look and Landrum up and what the heck they're talking about. What would promote a patient to say this might be of value? to them.
One of the things that's actually kind of noticeable, and some people have, is when they're sitting, they tend to sit, for a better word, on one cheek. In other words, kind of keeping the pressure off the painful side. Also, when they're sleeping, they tend to, if they roll over to the painful or the the pain generator side, they'll tend to wake up at night and have poor sleep habits because they have to physically roll over onto the other side to take that pressure off. So there's multiple symptoms that the patient will be feeling. And then this is when they would go to get a second opinion or opinion about what can I do about this.
Okay, so we have a question coming in that I'm sure you guys can kind of field. And it's a question that basically says the following. So what is the likelihood of after having one side done, someone needs the other side done? What do you guys think?
What is your thoughts, Lubos? I'll let you start. And what is your experience with that?
I couldn't hear, but is it getting the both sides done for SI joint fusion?
Correct. Yes.
Well, we've had patients before with my surgeon down in Bloomington also, that patient would feel so much better after the one side done that he would come back and basically ask the physician to do the other side.
Yeah, traditionally you would start with, the most painful side, see how the patient does, and then if need be, so there's, of course, there's a whole workup to determine whether that is the pain generator. So Dr. Landrum, as you know, with your patients, you do the SI joint injections, you do what we call provocative tests, which is just manipulating or moving the SI joint in different positions. And these will be the telltale signs whether that is the pain generator, if the SI joint is actually causing the pain.
Yeah, exactly. So there's definitely ways for us to be able to understand beforehand whether it makes sense, so we can figure out, is it one side, is it both sides, how has it responded after we've done this procedure, and whether we need to do this or something else. So one of the other things that we really wanted to kind of put forth was, what's the patient's experience after this? Because many people are like, I want to feel better, but I'm also concerned about how impactful this is going to be. When I think about normal lumbar fusion, they talk about 6 months, sometimes a year, to be able to heal. And this is a little bit different, wouldn't you guys say? Can you kind of expound on that a bit?
Well, traditionally, the patients would feel almost immediate relief once they wake up from the procedure. It's a very short procedure, usually around 30 minutes, sometimes 45, but it is a fairly short procedure. They shouldn't experience much, pain other than the wound, just where the incision was made. And that's basically just a few little sutures. The incision is about the size of a penny to place this allograft. But the only limitations are basically just, keep an eye on don't be too active. In other words, you could do everything you normally do, try to avoid stairs for a little bit, like a couple weeks, but just be a little bit conservative on your activity.
I'm sure that it's probably a bit challenging at times when patients are starting to feel better almost immediately for you to be able to rein them back. They're like, you know what? I'm doing everything. We're going to the club. We're going to go get some smorgasbord, get some food, maybe a Golden Corral. We're going to go do it up. So I'm sure it is a little bit difficult at times to kind of temper them. But when we look at that slide and what you're saying, the rehab seems like it's way shorter. We're talking, despite the limitations, maybe somewhere about a month or so, give or take, and that's a conservative kind of feel as opposed to months long afterwards. Would that be fair, or am I kind of putting words?
Oh, that is completely correct. That is completely correct. Most patients, like you said, feel great and they want to go out dancing or whatever, And it's just to limit them. Just, if they've had a procedure done, it's a a small fusion procedure. Just let it take effect. Let it calm down. Let it stabilize, and the long-term effects will be much greater.
That's genuine. That's definitely why we basically like Genesys system so much, because the cannula is literally the smallest one on the market to access the SI joint. And just like
Hey,
Steve,
Lugos,
yes.
1 second on that, because actually we had a question about that. Someone says, well, it must be a pretty big cannula to put that piece of bone in. So can you talk about how Genesys has made sure that that's not the case, and that it is actually pretty revolutionary in terms of its size and how it actually fits into the joint?
Well, Steve, is it a 10 or 12 millimeter cannula, correct?
It is actually 10 at the widest point, so it's 10 by 7. The implant itself, we do everything in millimeters, is 6 by 9, and it's 20 millimeters long. So in other words, the length is going to go down into the joint. We want to get it into the middle of the joint, because that's where it's going to stabilize or be most advantageous. And but it doesn't need the cannula to place this is fairly small. It's really the smallest on the market.
It is very small, and also for certain patients who would actually need or require 2 implants, we can access the SI joint through the same incision with the same cannula, correct?
That is correct. That is correct. Yep.
So again, like I said, I knew when I got you guys on that you're smarter than me, and I love it because they always say that you're supposed to have other people who are smarter than you in the room, because that always helps you get where you want to go quicker. And so I definitely appreciate you guys joining. That 10 millimeter, I understand, but sometimes, it can get a little bit convoluted. But if we put that in terms of English or inches, right, it's somewhere a little bit less than half an inch, right? It's between kind of a quarter and a half inch, around that way, from what I understand, at least looking at my trusty Google, that says it's 0.9393 inches when we kind of convert that over. So I think that gives people kind of that perspective on the size, where they're like, really, it's not as big as what they might have thought.
Correct. It's less than an inch. Definitely less than an inch.
So to that end, you guys alluded to this earlier. Genesys does some things that are a little bit unique. Why don't you guys try to tell us a little bit about that? I could toot your own horn from coming from me, but I think you guys can toot it better than I. So what are some of the things that you guys do unique in the space that allows for, patients really to be able to get such good outcomes?
Well, it's the design of the implant to try to make it as small as possible, but still be as effective as possible. There's a few other ones on the market, and they're much larger in all dimensions. And it's actually unnecessary to be that large of an implant. So Genesys wanted to make one that, was more towards the patient's anatomy, that would fit into the anatomy a little bit easier, and to have long-term outcomes that would benefit the patient.
Okay. So I know you guys also do something that's called a lateral SI fusion. Does this type of treatment prevent or kind of burn bridges, if you would, guys, and explain to me, does it prevent you from having a lateral SI fusion or having a lumbar fusion or any other surgery by doing this? And is there any issues with MRI compatibility? Which I know I have a number of patients that'll ask me, if I get this, can I still get an MRI?
Most definitely you can get an MRI. This is an allograft, so there's no metal in place. So that's why Genesys has chose to use a allograft implant. So you're not burning any bridges. The sacrum and the ilium are both made of bone. So this is a very similar type of bone that we already have in our bodies. And we're just placing just an extra piece of bone in that joint to take up any slack or laxivity or any space to try to stabilize that joint and not allow for as much motion as what patients are experiencing.
And the second part of that question was, does this prevent them from having any other surgeries? Whether it's a lateral fusion or a lumbar fusion, anything that Lou or Steve, that you guys might be able to kind of comment about that.
It does not prevent anything, any other types of surgeries. In other words, a lumbar surgery or going laterally, putting SI joint screws in from the hip side. It's actually the opposite way. If you have the screws already in, you're a little bit limited putting in this posterior SI allograft. But it doesn't prohibit anything from being another procedure being accomplished if need be.
Okay. So I know this is probably a little bit on a case-by-case basis. And I also know you probably would refer to the physician because in extremes, you would say, you know what, that may be more of a clinician's decision. But in general, can you be able to address this question that one of our patients puts forth? And that is, does this heal well with someone who has osteoporosis?
In severe osteoporosis, this probably should not be used just because it will not fuse correctly. You know, that's our ultimate goal is to fuse that joint. A lot of patients do have some sense of osteoporosis, and this implant works very, very well with them. But if need be, you know, there's tests that can be taken or diagnostic tests to see how severe the osteoporosis is. But traditionally, in most patients, this can be used.
Okay, I got to tell you, so we have a number of our viewers that are patients and really support us well. And I don't think this is coming because of things I've said, because I haven't really done anything but make some jests here and there and been kind of like, you know, the comedic and the MC for this. But because of the information you guys are saying, we have a patient that says this, sign me up for the next one. So you've already started to try to convince, you know, some of our viewers about, you know, both the value that's there, but also the safety that's there. So can you talk about, in particular, the posterior approach and the safety that's present inherently in it, and what are patients potentially having as kind of balances between saying, hey, we're looking to get benefit, but I'm also not looking to have a worse experience. Can you talk a little bit about that as well?
Yes, most definitely. So this is, you know, going posterior, we're working away from any neural or vascular structures. In other words, we're not by any major blood vessels or any nerves. We're working, actually, the joint goes from medial, which means like towards the middle, out laterally. The joint usually goes, say, 15 to 25 degrees medial to lateral. So we're not by any neural or vascular structures. Now, when you do a lateral procedure, putting those screws in, you're actually aiming for those neural and lateral structures that you really have to be careful about. But in this instance, going posterior, it's a very safe approach. There's never, I knock on wood, there's not been any known on any system out there of any issues of bleeding or neural damage. And it's a very, very safe procedure. And Dr. Landrum, I think you should probably just talk a little bit about your experience in using this device. What is your thoughts?
For a minute, it looked like you wanted me to talk about it. It was like, no, we'll just keep Steve and Lou talking, man. Everyone wants to hear what I understand. So, first and foremost, I would say, to me, I think a posterior approach to the SI joint, it really mimics both physicians as well as patients' experiences with that very problem. So most people don't walk into the office and say, hey, you know what? I got an SI problem. Help me. No, what most people say is, hey, I got a back problem, or they mention some of the things that you talked about with having the problem where they're sitting on one cheek, or they're having that problem with position, right? And it just gives them a heck of a time. And so how we normally get to that is by doing an SI joint injection. There's a lot of different ways to do it, but there's some pretty common ways that are really more prevalent than not, where we approach the joint, we can see it under x-ray, we go into the area, and we give steroid tests there. There's some other fancy things that we could potentially be able to do, but at the end of the day, that's kind of the way of that we would sort of at least hopefully get some initial benefit. And the most, I would say, very svelte manner of how this is constructed is it mimics that same experience for the patient as well as for the provider, because it uses the exact same vantage point of how we enter into the joint with some degree of semblance. We look for similar landmarks. We go into the same area. And what we do differently is, as opposed to us putting a substance that's going to be there, and dissipate, instead now we're putting a product that fits right in there, that's almost like it was made for it, that decreases that degree of instability that's causing all the pain. So now you can be able to have that resolve, have more structure, and be able to do it in a manner that is very well put together. And that well put together piece, it makes for a fairly effective and efficient procedure. In many hands, it's as fast as a half hour. Sometimes maybe it's much shorter than that. And I know we've had similar experiences, just doing that for some patients that we've treated. It's been a really rapid procedure that results in a big return for patients. And we've had some patients already say, hey, you know what, we're feeling better, we're doing better. And I think it's a game changer, would probably be the way I'd kind of characterize it. I'm sorry if I took up too much time there, guys. You guys were like, oh my gosh. And he talked for like 15 minutes. That's supposed to be our show.
I just wanted for you to share your experiences with the experience.
He never gives it back. Just keeps shooting. So, all right. So, guys, let me ask you this. I know you were going to stay a little bit away from talking about lateral fusions, but I want my audience to be in the know. And I want them to understand everything that's going on. Is there a time where you might pick a lateral approach in lieu of a posterior approach? No offense, Lou. I just wanted to say that. So is there a time where you might pick lateral instead of posterior? Or would you almost always go for posterior and then reassess it?
That's a great question, Dr. Landrum. And actually, I'm going to come back to one of your patients who was asking about osteoporotic patients. So maybe in that instance, I would maybe recommend lateral SI joint fusion, just to kind of fixate and bring that joint together with 2 or 3 titanium implants instead of going just posterior. But I got a really good experience with both. And what I like about posterior, that it's definitely an outpatient procedure. Like Steve mentioned, it's safe, and the patients are doing well almost immediately.
Yeah, there can definitely be a difference in terms of the experience post-operatively for patients from a lateral approach versus a posterior. And as you guys know incredibly well, that lateral, you have to go through some tissue in order to get to the area, and you got to go through some other structures as well. So that can present, for a much more involved and a little bit more of discomfort than what you might with the posterior.
Most definitely.
Most definitely, yes. And it's a lateral procedure isn't as much tissue sparing, anatomy sparing, because you have to use about 9mm drill to get into the joint laterally with 2, possibly even 3 implants, titanium implants, instead of basically doing a needle procedure from the posterior side, using a cannula, going in with a really, really small drill, and then dropping in a piece of bone.
Okay. So from this posterior SI treatment options, do you guys have any stories of any patients that they were astounded by like what you did, and they're like, man, this was just, it was more than what they expected in terms of a positive outcome?
You're exactly right. I mean, most patients have come in and they're so painful to begin with. They've gone through the whole conservative treatment of the injections, and a lot of times they've been on medication and things like that. having this procedure done, they are usually so thankful. And the patients I have met afterwards, said, I wished I would have done this sooner. So there's, traditionally very, very good outcomes with this procedure.
Okay. Well, guys, I don't want to keep you too long, and I appreciate you working with our technical difficulties and being good sports with me, making you have to talk to me like a fourth grader and all those type of things. But at the end of the day, what I want is to make sure we have content, not just for people who are watching right now, but for people who might watch this in the future, so we can really refer to them and they can have an understanding about what are they getting into, how is it going to help them, what can they expect afterwards, and really what's the value to them. So in summary, let me ask you maybe a couple more questions and then I'll get you guys out of here so you can kind of get ready to enjoy this 4th of July weekend coming up pretty soon. So first of all, are there any questions that I neglected to ask that you feel like, you know what, this would be something that we really want to kind of mention and hammer home?
I think just talking to the patients about maybe the workup of getting to that point where they would need the fusion procedure. In other words, when they come to your office, you would do some of the manipulations of the SI joint or the provocative, we call them provocative tests, that are actually required, to have this procedure done. Also the injections too, using just a local anesthesia and not a long-term corticosteroid to help them determine whether this joint is actually the pain generator. So in other words, I think traditionally, I think you have to do 2 of those injections. I believe it's a month apart, and that'll help determine if this really is the pain generator. You want to exhaust all conservative treatments first, and the fusion will be, the final procedure for these patients.
Okay. Well, gentlemen, I definitely appreciate you coming on to kind of give some explanations for our patients and have them understand what posterior SI fusions are. I definitely appreciate you teaming up with our office to be able to provide this kind of unique offering. I would say, although you guys know quite a few physicians because you deal with them day to day, doing this, there may not be quite as many docs around the country that are really saying, how can we be able to provide and leverage a technique for a patient that provides long-term sustainable treatment options. And so we hope that not only in you partnering with us, but being able to expand this to other patients throughout the country, it ends up making, more of an impact and quality of life for a number of individuals.
So true.
So to that end, maybe you guys might be willing to come back sometime in the future and we talk about either some interesting cases or have some patients maybe join us and talk about, their experience that they had post-SI, if that's something that you're open to.
That'd be wonderful.
Yes.
Most definitely. It'd be wonderful.
Okay. Well, again, gentlemen, I always appreciate, people coming on. I definitely really appreciate you guys coming on and dealing with my malarkey and stuff about allografts and cannulas and the things along those lines. But I really appreciate someone who can be able to come in and talk about a procedure that's unique, that doesn't burn bridges, that can help really address a unique problem that doesn't have people kind of going up and down, but instead provides them some relief that can be able to be sustainable so they can do what it is that they want to be able to do.
That's correct. Well, thank you so much for putting this together. It's been wonderful.
Thank you, Dr. Landrum.
Thank you so much. Again, for those of you who are joining us for the first time, whether you're on Facebook or on YouTube, we obviously have both channels. So if you're interested, by all means, please take a look and check us out. This is the link to our YouTube channel below, so you can be able to kind of jump on that and figure it out. And really what we try to be able to do is to help patients understand what their options are, to know that there is hope for a number of different conditions that exist out there. And we really want you to be able to figure out how to be able to win that fight against pain, punch pain in the face, and get back to leading the life that you deserve. For those of you who are not so much video oriented, which you probably are because you're watching this, but be that as it may, if you would prefer to read things, we have a huge, phenomenal newsletter that's in place that has a whole host of different topics. So definitely check that out. It's on our website, cuttingedgepain.com. It can be able to lead you to having an understanding about how to be able to deal with pain and how to be able to address it appropriately. Again, gentlemen, thank you so much for being here with us. Thank you, viewers, for being with us, and join us next Thursday for us another interesting topic. Take care. Bye.
Thank you, Dr. Landrum.